Good afternoon, everyone. Thank you for joining us. We had a few announcements at the beginning of the webinar. We have Dr. Powers with us this afternoon to present on some very important topics concerning elder abuse. And then I will also post in the chat some of our upcoming events throughout the summer. You might have seen us save the date for an event in October. So we're so happy to be continuing to partner with ENCORE to provide these webinars and in-person events concerning the care of older adults and building community. So let me not waste any more time, and I'll introduce Dr. Powers to you all, and then we'll get to hear from him this afternoon. So Dr. Powers is a professor of medicine at Vanderbilt and the director of clinical innovation for the Tennessee Valley Geriatric Research, Education, and Clinical Center at Veterans Hospital in Nashville. In addition to serving as a personal physician to many older adults, Dr. Powers trains new physicians and is engaged in nutrition research and aging. He is the author of numerous publications on geriatric care and models of quality improvement. Dr. Powers has worked with teams of healthcare professionals for decades caring for older adults. Today, he will address us on the topic of elder abuse. Thank you, Dr. Powers, and welcome.
Thank you for that kind introduction, Stephanie. And it really is my pleasure to be with you. And I am so glad that ENCORE Ministries and the Gerontology program at the UT College of Nursing, UT Chattanooga College of Nursing, and the Engaging Communities Tennessee program are sponsoring this series. I'm going to talk with you about something that's, on the one hand, very serious, but on the other hand, tells us a lot about caring for older adults. And I'm going to speak to you as a physician who takes care of these patients. These actually are real, authentic cases that I'm going to present to you. And I'm going to try to look behind the scenes with you, kind of let you see what's going on in the clinician's mind. And I can see from the audience so far that there are so many people here with a lot of experiences running programs, but also people in the community and people from faith organizations. I hope that you will have some questions and some comments because I think this is a topic that touches so many of us and the families that we work with, and we can see it from so many perspectives. So if you'll advance to the next slide. Stephanie, I have no disclosures. These are all presented with no plans to reveal any identities and is all from a teaching standpoint. And I hope that all of you will be able to increase your recognition and ability to report and respond to any older adult who's vulnerable with suspected neglect or abuse or exploitation. And I hope that you'll have some information, some familiarity about reporting techniques and a little bit about what is done for follow-up. And I'll be giving you the healthcare professionals side of that, not an attorney and not a public official, but there certainly is a lot of interplay between those fields. I'm going to talk with you about provider assessments, documentation, and also how I hope that you will also understand better the processes for what it's done for elder abuse cases and the role of the healthcare professional in furthering that. So next slide. I'm going to jump right in with a case. This is a 79-year-old lady who is brought to our attention because she's been left alone by her family for several days. She appears wasted, confused, has several bruises on the arms, and states that she wants to go back home with her family. And the next slide. While I talk about this, I want you to think about what elder abuse encompasses. It could be many different types, physical, emotional, financial, sexual, as well as neglect. And we know that seniors with dementia, disabling illnesses, and heavy care needs are more likely to be victims of abuse. And I want you to think about what's the difference between competency and judgment. So we'll go back to the case. Back one slide, please. what's going through my mind here? So this is an older woman who's brought in, and we'll place ourselves in an emergency room setting. That's where this often happens, but it could be an office setting as well. And we're told that she's been left alone by her family for several days, and she doesn't look very good, does she? She has some evidence of some injuries, but still she says that she wants to return home to be with her family. Well, as I think about this, I of course have to say that all of us have to be concerned. Could this be neglect, or could somebody be injuring this person? Could this actually be some abuse? Could it be that this is actually a dementia case? In other words, this woman may not be able to care for herself and maybe bruising herself and maybe falling, perhaps. Maybe she's afraid of losing her home. No matter what the circumstances, home is where she's comfortable, and she would want to go there even if she can't manage by herself. Could it be that there actually is family involved, and that maybe she's feeling overwhelmed and frustrated, or they are with her because she won't cooperate? And what's the likelihood of all those things? Well, we have to think in big terms here because we don't have much information, do we? Could it be that she really is being injured, or could it be that maybe she's refused care and maybe there's some dementia going on? So we really have to investigate a lot more. If we were in the emergency room, we certainly would let Adult Protective Services be aware of this. And unfortunately, because she does not have a safe place to go to, we would have to place her in the hospital. That's important because it's a safe environment and it allows us to do more evaluation. It would be very hard to immediately send her anywhere else. We really don't have that liberty to do that. Even if family were to appear, we would have to be concerned about their whether they're acting in her best interest. So we basically would have to admit this person. And again, if this were in a clinic setting, if this were in a community center, we would have to send her to hospital, and an admission would be very appropriate. In addition to talking with the social worker and the Adult Protective Services being notified, we would evaluate for medical problems and dementia. And yes, find the family. We have to get more information. We have to know. Sometimes families can be hard to find. Sometimes they actually aren't aware of situations that have happened, but we definitely need to find them. And sometimes we can find them by telephone. Sometimes it takes a call from local authorities to actually find the family and bring them in, and that's so very important. And I'm going to stop for a minute here, and it looks like we don't have a large crowd here. And Stephanie, is it okay if we open it up for questions from the audience, audible questions here? You are welcome to type into the questions and answers, but I think that probably just, what do you think about this lady? What do you think's going on, and how would you respond from your own perspective? Any thoughts?
Definitely, I would follow along with exactly what you have said, but one other is she on any blood thinning medications that would make her very susceptible to bruising?
Absolutely. Right. We want to do a thorough evaluation for her. And if she had some medical records at that facility, that helps. If not, hopefully family can provide more information. Hopefully we can get that within a short period of time. Some blood tests can indicate whether or not she's on blood thinners too. So yes, we have some laboratory evaluations that can help. And this is not a guess what I'm guessing game, by the way. This is exactly what we went through with this lady. Any other thoughts about the reporting, about what you think of family? Any? ideas?
I'd want to know if she had a UTI, if perhaps this confusion is delirium rather than dementia.
That's right. That's right. And that we know that a medical problem will predispose an individual to confusion and perhaps not acting appropriately. And perhaps if they had an underlying dementia, they're at higher risk for this. But states of dehydration, infection, injury are all possible causes of confusion, which we would call delirium. Absolutely.
I have a question. I was just wondering, since there are some red flags, would that trigger the medical professionals to have a list of questions to ask her or even the person who brought her in, that would give you more of a picture of what's going on in her home life and also in her mental and physical state?
Absolutely. I think that we really need more information. If there is somebody who brings her in, they might give us some clues. When family shows up, we'll get more information. But yes, we definitely need to have more information, some corroboration as well. I'm not sure that this woman is really able to tell us everything that we need to know and everything that's in her best interest. For instance, her medications, that would be unlikely that she could help us there, but she might be able to recognize family members. She may be able to tell us a little bit about her history, where she lives. Maybe we can tell even from what she says how confused she is. That could be very, very telling as well. Right. And I think it's very important to point out that if you're working in the healthcare field, you don't want to cause trouble. You don't want to call the authorities unnecessarily. And it turns out that although we are required to report suspected cases of abuse, it's really difficult to monitor that, isn't it? It's an ethical thing on our standpoint, on our point to, our part to do that. But it turns out that very few cases of suspected abuse, perhaps only 30%, we believe, such as this, ever get reported to Adult Protective Services. So there's a great underreporting. It is thought that somewhere around only 1 or 2% of older individuals ever get reported for having abuse, but we think that it's much more prevalent, probably close to 20% of the population, which is huge. And most of that actually occurs in the home. It's not in a nursing home. It's not a fall in the hospital. It's not a disgruntled nurse arguing with a patient or yelling at a patient. It's not that. It's generally overburdened caregivers, and we're going to talk about that in just a moment. Well, I agree entirely with all of those comments. And yes, APS referral is appropriate, and they are required to do an investigation. Let me tell you what happened here. There was indeed a urinary tract infection that was identified. She was not on blood thinners. She probably had been falling. She had lived alone and has progressive dementia. To the point where she was argumentative with families and the uncooperative. They would try to bring her meals, fix food for her, get her to come live with them. No way, I'm living alone. I'm going to be by myself. Thankfully, she wasn't driving, but she really had gone beyond the point where she could care for herself. So a lot of what we were seeing actually is neglect. And that couldn't be known at the start, but that is indeed what happened here. APS did come and found that there actually was a family involved, but they kind of were waiting to see what resolution would come. And it turns out that after several family meetings, after the woman was feeling a little better, we corrected her underlying medical problems, made sure she was not dehydrated, and was comfortable, still demented, but included in a family meeting. It turned out that the most appropriate level of care for this woman, if she wasn't going to live with family, was going to be an assisted living residence. But I might just stop here for a moment and ask your thoughts. Do you think the family would be liable for abandonment with the circumstances that you know now? What do you think APS would think about this plan? They came out and investigated. We all met with them. Well, they actually have a number of options. If it looks like there is a treatment plan that is going to at least resolve the issue, at least for the short term, and there's no immediate harm to the patient, to the individual, that satisfies them for the most part. If it looks like there is no place to go, finances might enter into that. They actually can place an individual like this in a nursing facility for a while until sometimes these disposition issues take a lot longer to work out, financial ones, finding other relatives to take responsibility. In this case, they felt that it was really a case of dementia and that the family had tried. It wasn't obvious that they had refused to see her. It was more apparent that she was very uncooperative. However, the family and the individual did agree with a change in environment. And actually that is really an upgrade for her from her current condition. House was not in great repair, and she really actually her quality of life would improve, but thankfully she was agreeable to this. That doesn't always happen immediately, but in this case it was that happy ending. And what ended up happening over time was that the family was able to sell the woman's residence and use that income to help pay for assisted living. And we're going to talk about locations of care. Medicare, Medicaid do not cover assisted living costs. Basically, the patient and her family has to. But I'm going to go talk a little bit more about risk factors for elder abuse. But before I do that, any questions about that situation and its resolution? Okay, well, we all, the staff and I learned a lot about APS. We also were happy to see that most families, and this is the case, most families really do try to take care of individuals, but it was really the dementia, the progressive dementia that really was the major factor here. And although she came in having fallen, little dehydrated urinary tract infection, she was not in immediate jeopardy of severe injury, and so basically a happy outcome. So APS was pleased with that situation as well. We'll advance 2 slides, Stephanie. And let me talk with you about the classification of elder abuse. We try to put them into about 6 different categories. And so financial abuse relates to the exploitation or misappropriation of an older person's assets for personal or monetary gains. And it's actually one of the more common forms of abuse, and families are often related to that. That was not occurring in this instance. Physical abuse consists of willful acts carried out with the intent of causing pain or injury. And I'll talk with you about some of the risk factors for that. Imagine trying to work with this woman, trying to get her to accept help, accept meals, and perhaps go to a safer place, such as an adult day program. A lot of arguing, I'm sure, goes on behind the scenes there. So physical abuse can be a sign of frustration from the point of the caregiver. Understandable, not acceptable. Sexual abuse includes non-consensual sexual activity with a non-consenting or incompetent older individual. It's not considered to be a real common form of abuse, but often is, of course, a very serious thing and sensitive topic for many folks to even talk about. Emotional abuse includes willful acts or threats intended to cause emotional anguish or pain. Again, caregiver distress is often at the cause of that. And caregiver neglect is the most common form of abuse and consists of intentional or maybe even unintentional failure of the designated caregiver to meet the needs necessary for the older person's physical and mental well-being. And you might have suspected this family. In fact, we all worried about that when we admitted, but as it turns out, they truly, I believed, were trying to do what they could. It was the individual, their mother, that actually would not cooperate. And again, it's an illness. It's a sign of one of the signs of dementia. Self-neglect is often seen in folks who do live alone, who do not have a lot of family support. I do work in the Veterans Administration. We see a lot of that. Self-neglect is present among folks who live alone, who by choice or because of just lack of resources don't have any help and suffer some harm as a result of that. And there are some risk factors related to the caregiver, which I wanted to get to next, and then I'll let you ask some more questions. I think that it's important to think of the support system that these individuals have or don't have. I take care of many dementia persons living with dementia, but I actually have two patients in each case. I have the caregiver who's every bit as much in need. And so I really feel for them. Do you know that there are somewhere around 43 million family caregivers in the United States? Average age is in their early 60s. So many of them have left work, left situations where they could get more support in order to care for loved ones at home, and often without a whole lot of help. As you know, programs like Medicare can't cover a lot of the non-skilled needs that these individuals need to supply in the home, and Medicaid only provides a portion of that. So really a lot of it's on the family, on the individual. So what are the risk factors for the caregiver kind of not being able to be up to the job? Well, cognitive impairment in the patient or perhaps the caregiver. We call this a dual dementia family. Oh my gosh. And this seems to fit the description of this first case that I mentioned to you. Makes it very difficult to provide the care, the supervision, the monitoring, and the direct care that is required. Perhaps the dependency of the caregiver on the patient or vice versa. This might be financial, it might be emotional, there might be role reversals. For instance, a man and a wife living together, if the gentleman becomes demented and the wife had depended on that individual, on her husband, for most of the day-to-day care of the home, for going to get the groceries or so, and more had a traditional role, was more the homemaker, and then found doesn't have the help, it might be overwhelming for her to take care of him and to keep the home up. It's herself, and we also see this where the gentleman might not be have the skills of a good caregiver, depending on the wife to do most of the care of the children growing up. And now he's the caregiver, and he just really doesn't have those. He's a bad cook. He doesn't understand how to be sensitive to illness, and so dependency is a very real issue. if we have a substance use disorder or a mental illness in the mix, or a history of abusive behavior just from personality disorders, that always makes it worse when there's a caregiving role that then has to be assumed by one of the family members. Financial distress is another one. We know that finances are limited and people on fixed incomes, retired, older adults, but also illness itself causes a lack of resources. That you expend a lot of funds trying to hire caregivers, trying to meet the needs, transportation, medication costs, all can take their toll. Isolation as well. We see this not only in rural areas, but certainly there, but also in urban areas where perhaps they don't know their neighbors, or they neighbors that they had known in the past have moved away or passed away. So isolation, particularly for individuals living alone, makes it much more difficult. Perhaps people try to drive when they shouldn't because somebody has to go to the grocery store and get supplies. It can make the situation much more difficult. A caregiver who can't get away to visit with friends or have a break, a respite from the caregiver role, is at risk for either inadequate or sometimes even abusive caregiving. The living arrangements may be inadequate or poorly kept. House, perhaps in poor repair, plumbing may be a problem, leaky roofs, or perhaps inadequate space. Maybe the sick individual needs their own room with adaptive equipment, hospital beds, and a small apartment may not be able to accommodate all of that. Bathrooms with adaptive equipment as well, grab bars, walk-in showers, very difficult to retrofit into some older dwellings and very small apartments. And then other things that happen in the family: death of a child, death of the caregiver, illness in the caregiver, and financial situations are all things to be considered. When I see a list like this, I tend to kind of feel sorry for caregivers rather than immediately critical of them. But let me stop for a minute, because I've given you a wealth of information, and I'd love to hear some feedback from you and questions.
I was just wondering, like, when you find a family that's obviously in distress, or they're having a hard time managing the care based on a number of factors, are you able to give them any supportive resources that could be helpful?
Yes, there are a lot of resources in the community. Knowledge of those resources is a challenge for new providers that perhaps don't have a lot of experience with referrals in the community. In a hospital setting, emergency room setting, we have help. We've got some good social workers. We've got some good nurses. Sometimes home agencies encounter these issues, and they have help. But yes, I find that learning the community resources and being able to make those referrals is difficult for providers. I'll speak about physicians there. They often feel their role shouldn't be there, but it is. Knowing what resources are out there, how to help families is just so very important. And if you can't provide that knowledge, to get someone that can. If there's an urgent situation, as I presented here, certainly Adult Protective Services will come in. You have some help with that. We pay tax dollars for this help, and these are the people that need it, and they will provide for services. Maybe a case manager might be assigned. If this person had health insurance, we should notify that plan, and they will probably also provide a case manager, because this person is a high-risk person for repeat hospital stays that they don't want, or perhaps worse health outcomes. And even though they may not cover the assisted living residents, the person still is on their health plan. And so making sure that they have other services available. There may be homemaker services if she weren't put in a assisted living residence. They may perhaps be able to provide some assistance with homemaker services. Some of the managed care organizations, some of the Advantage plans, Medicare Advantage plans, are providing for, as I think the proper term now is, health-related social needs. Not full expense, but contributions to help offset some of the cost of that personal care that makes a real difference in keeping a person functioning at a higher level in the home.
Thank you very much. And I'm also going to put it in the chat. I'm with Southeast Tennessee Area Agency on Aging and Disability. Many doctors' offices and police officers, social workers use our information assistance line. So I'm going to go ahead and put that in the chat. And we do provide services for adults 60 and older.
And I want to give a shout out to the area agencies on aging. You are now not only a repository of information, but you are actually providing case management services, and that is wonderful. Thank you for what you do.
Thank you for what you do. Thank you.
And as a clergy, I know that was always one of my networking places was area aging. And so thank you. Thank you. Thank you.
Mm-hmm.
That's right. We find that clergy are one of the most sought after advisors by caregivers. Who do you go to when you're feeling overwhelmed? Well, clergy are a natural. And so providing information to clergy is so very important too, so that they know the resources and can make the appropriate referrals and recommendations.
Now, I work in congregational care at my church. And in the past, we have helped the caregiver in so many ways to be supportive of them, to be able to bring people in to sit with the person so that the caregiver can get away for a few hours. They can go shopping, then get their hair done. They can attend a class or do something just to get away, get their mind off. And come back a little bit more renewed and refreshed. There are times I'm working with a lady now, just trying to pull her out of the house a little bit at a time, just to attend a gaming afternoon with several of us, because she's doesn't like leaving her adult son, who is so prone to seizures. And she's so scared of, leaving him there, even with her husband. She feels like she has to be there all the time. She has to do it, and she doesn't. So I'm working with her, just to get her out a little bit more. But churches, congregational care can provide a wealth of help for these caregivers that they need.
You're absolutely right. In fact, there's actually some very good evidence that if a family, particularly dealing with a person living with dementia, can get as little as 10 days a year, even in broken up in terms of respite, a break from being the caregiver around the clock 24/7, that individual can stay in the home setting another 2 years. It is that powerful. 10 days for 2 years. That's incredible. So it's very meaningful help to the caregivers.
And then the pros of that.
I have an ethical dilemma as a pastor, but also I'm a social gerontologist, worked at the VA in Richmond. But I have a previous pastor had worked with one of my parishioners. She's living in a house that literally is falling down around her. She's totally cognitively intact, but I'd say judgmentally impaired. That's not new. And she won't leave her cats. And their housing in our area is very difficult to come by. So finding something she can afford where she can take her cats is near impossible. do I call Adult Protective Services knowing her house is in such bad shape, or she's got the right to make some decisions. What's the right thing to do?
I'm going to err on the side of there's no immediate jeopardy here. It's not what you or I would choose or choose for her, but there's no immediate harm here. She is getting enough to eat. She hasn't fallen through a hole in the floor.
Almost.
Almost. And I've had some folks like that. What you should know from a medical standpoint, something will happen. A urinary tract infection, pneumonia. She will come into medical care, and that will be the transition. That just happens so many times. And I can give you similar examples as well. I think what you risk, and it's not wrong to call Adult Protective Services. You are entitled to do that if you feel, in your judgment, that there's this is just intolerable. What you risk is that your relationship with her, and many families, also the caregivers, if there's family involved, get so that's something to consider. It's like calling the cops, and they're doing the right thing, and you are not at fault. But you have to balance that, and it's a delicate thing. I would say, from what I hear from you, that I would let it go. Keep encouraging her to do something else. Maybe fewer cats. Maybe she could volunteer if she's able to do some volunteer work at an animal shelter and try to help that way.
Thank you.
But she would have a better quality of life if she were to sell the place and go into assisted living. And then she could take care of the pets at the assisted living residence. But many people go to assisted living on a have to rather than a want to basis. But unfortunately, their quality of life suffers as well.
And some do offer a respite opportunity and that kind of gives you like a little foothold in introducing them to assisted living.
One other comment, having also managed assisted living facilities, is aid and attendance is available to those who have either had 1 day of active duty, or if their spouse has had 1 day of active duty during wartime. And many of our aging people, including myself, are in that category. So she might be available, be able to use that, but she doesn't want to. So.
Well, I'll just give another shout out to the VA, because they provide so many benefits that are what we call, in Medicare terms, non-skilled services. So homemaker, home health aid, respite care, adult daycare, wonderful programs. And it's just not in the Medicare, I guess, the benefits. And so you can't do that. But if you do have someone with VA benefits, letting the family know, letting them talk with a VA social worker. I've seen many complete reversals in the caregiver's situation, just wonderful outcomes with that added benefit. So if you are aware of that, of the person's veteran status, that could be one thing that they can get from the community. A lot of support there. Well, let me go on. You, by the way, thank you for all your wonderful comments and questions. I'm going to give you another patient here. Some similarities, but it'll allow me to talk about a few other things. This was a woman who we also know had advanced dementia. However, concerned daughters lived nearby, and a neighbor reported to the Department of Human Services, Adult Protective Services, because she was wandering in the street. Oh my gosh. Next slide here. I want you to think about the person's decision-making capacity, and what is autonomy, letting a person make their own decisions, versus our acting what we think is in their best interest. What is beneficence? So, next slide here, and so the things that I would be concerned are about, again, is this neglect or abuse or maybe inadequate support in the home? And what evaluation would I make for immediate needs? How's the family meeting going to go with the daughters? They're going to have to be involved. And how are we going to make referrals for resources? So in this case, this woman did not have to go into the hospital and came into the office. And I was able to get the daughters to come. So basically have a family meeting in the office. They felt that they would still like to keep her at home with some additional help, some supervision and personal care, maybe assisted living in the near future. This woman was actually still able to care for herself. Her judgment was poor. And so my questions to you are, what are the usual care needs for the different stages of dementia? And maybe describe what resources are there in the community for those living with dementia and their caregivers. And how would you counsel the patient's daughters? Some of you are in the field here, so fire away. What do you think about this case? A woman wandering in the street, and they come in, and there you are with the individual and the two daughters. What do you ask them? What do you think that conference is going to go like? Well, the patient generally doesn't say much. She feels like people are criticizing her, and we are. We're displeased that she wandered out in the street. There's a safety issue there. Well, it turns out that similar to the other case, and in my experience, 99% of families are trying to do their best. But both these women, the daughters who lived nearby, were teachers, so they worked during the day. They couldn't be with their mother all of the time. And do you have any thoughts? Is it required that she not be permitted to return home? Would you call DHS?
Or
Well, it was. I'm sorry, they already did.
is there
The
an
neighbor did.
is there an adult daycare, that they could participate in, so that while the daughters were at school, then at least mom was being, seen and socializing and doing all of those type of things, and then perhaps they could pick her up and take her home afterwards?
Sure. So use of perhaps a senior center or an adult day program, depending on her level of dementia. Early dementia, even some mid, can still participate in activities in a senior center. But there are adult day programs for more advanced dementia. Sure, I think investigating that. The other would be to get some in-home services. We'd already talked before that this would have to be something that the family would have to provide, but it's possible that if she had a Medicare Advantage plan, that because of her diagnosis of dementia, she might be eligible for some in-home services, and that's changing. It's not a given for all programs, but in some cases that's a possibility. Well, the daughters were very agreeable to that. Despite working for the public school system, they weren't aware of other public resources and community resources for dementia, and they felt it was all on them. So they actually needed a lot of help. So referring them to a support group so that caregivers could compare notes, basically share best practices and support would be very appropriate as well. And indeed, we did that, and it was a happy outcome. I continued to follow this woman, and they eventually did decide on an assisted living residence, but it required a lot of financial planning and selling of property. And this woman was not able to make those decisions for herself, so that she actually had to be declared incompetent, so that and her daughters appointed to act on her behalf. Something that if if we can, we try to advise families to do this before things become so advanced with dementia that the individual can't make these appropriate designations. The other is to have an advanced directive, in other words, a living will. And if we identify somebody with an early stage dementia, we know that this is going to progress, but to make the family, make the individual aware that this is the time to make your plans, make others know what you would want for the future. So very important to advise. Well, we had several meetings. It wasn't all a one-time meeting that accomplished all of these ends, but indeed, that was the process that we went through. And Adult Protective Services felt that things were under control. And again, they did not have to place her in a nursing facility temporarily for protection, and there was no reason to proceed with any prosecution or anything. So that was a happy ending, but it sure scared the daughters. And thank goodness the neighbor was able to take appropriate action so that the woman was not injured by any passersby. Well, I'm going to go to the next slide here and talk a little bit about levels of care. And adult day programs are readily available. Most of them are covered by the private pay. In other words, the family has to pay for this. A few programs will pay for adult day programs. Again, a few managed care organizations who will provide this, usually with a case manager assigned to a high-risk individual. VA does cover this for individuals who have VA benefits. And these programs sometimes will even provide transportation, which is a real benefit to the family. The caregiver may not be a driver, and generally have a very good track record of keeping individuals functioning at home in the community, giving the caregiver a break, and even if the a person went there for a half day, a few days a week, one day a week, a couple days a week, it's of benefit to the caregiver. And again, like assisted living, people often go there when they're told to, or when the family forces them to, rather than when it could be actually a very engaging opportunity to socialize. They sometimes will have activities. I was even aware of a few places that tried actually some employment. Those were factory parts that were brought in. People would do some simple assemblies, but the individual would actually earn a paycheck. Not a lot, but they felt worth something had been accomplished, and people appreciated what they did. But there are various ways to run adult day programs. Respite care is that break for the caregiver. Many respite programs are provided from community support, voluntary support, and have a voucher system where a family might be designated a certain number of hours a week or a month, and depending on the finances of the charity that's involved. In Tennessee, we have a Tennessee, used to be called the Respite Coalition, now the Tennessee Caregiver Coalition, and they receive some grants as well as United Way funding to help offset the cost of that. But a very great benefit, again, as little as 10 days total in a year, can provide a long a benefit to the family and the patient and offset a nursing home placement. Assisted living covers many different levels of care. The basic care of an individual in assisted living is often assessed by nursing staff. I think nurses have a very good background on what needs there are and how to aim the care to the individual, whether they just need congregate meals, or they might need some assistance with bathing, or all the way to dressing and medication administration. People can live in assisted living for quite some time. And in fact, we are as long as there's a care plan in place, even individuals who are experiencing a terminal illness can remain in place as long as they're being visited by hospice. So it used to be they would have to leave, but even that is permitted. And other services can be brought into assisted living. As far as Medicare is concerned, assisted living is considered living at home. It is the individual's residence, but it allows for home health services as appropriate for the individual. Boarding care is not generally highly regarded, at least in our state, but it is another level of care. This is often provided by private individuals, so small boarding care facilities. The state legislature just passed a licensing act now that they have to have a license, and the thought was that I think a good one, that it would help improve quality or maintain, it would have some standards for care. So these are often small family-oriented facilities where generally minor care might be provided, such as congregate meals, maybe assistance with bathing, but that individuals could care for most of their own basic needs. And there are many of them. And again, they used to be unlicensed, and that's changing now, at least in Tennessee. Nursing homes have two levels of care, and you should know that in our state, in Tennessee, 70% of nursing home care is provided by Medicaid and care. So most people who enter the nursing home have both a medical need of nursing home care and also the financial need of Medicaid, so that they have to qualify for that. Intermediate care, meaning not needing skilled care, is very hard to get into initially, although many people who enter as skilled often stabilize and then go to level 1. Nursing home level 2, the skilled care, is where many individuals who leave the hospital are sent, and they have special needs, for instance, oxygen requirements or wound care, or perhaps some physical therapy after a hip fracture. Things like that would be skilled care. But once they stabilize, if they continue to qualify for nursing home care, they would transition to TennCare, to Medicaid, and then be nursing home level 1. As they entered the skilled level, they would be Medicare patients, not Medicaid, but that's still just a small in proportion to the total number of residents in nursing homes who are paid for by state Medicaid. And maybe I'll just stop. That's, again, a lot of information, a crash course in social work, I think, and see if you have some questions or observations.
There is one question in the chat that says, does hospice provide a service for elder care prior to the end of life services?
Yes, to qualify for hospice care, which is a Medicare benefit. So the benefit states that you have to have an expected life expectancy of 6 months or less. And cancers are a little easier to make that prognosis with. Some things like advanced heart disease, liver disease, a little harder, dementia even more so. But if at least two clinicians think that the person has 6 months or less, generally they will qualify for hospice care. Prior to that, perhaps you were talking about palliative care. Palliative care is a philosophy of care, comfort measures, and may be appropriate at any level of advanced disease. Unfortunately, isn't specifically covered by Medicare or Medicaid, but the other services, the office visits, the referrals, may well be. But once they have officially hospice care, they become Medicare eligible and can actually be placed in facilities if that's required, although about 80% of hospice care is provided in the home still. Did I answer the question?
I believe so. Any
Okay.
other questions
Oh,
online?
okay. Somebody who was kicked out of hospice. Yes. Somebody who survives the 6 month. Yes, that's actually very common in dementia care. I take care of a lot of dementia patients, and I've had hospice say, Dr. Powers, we want another opinion because Medicare doesn't agree with you. And it's only because the family's been such great providers. I had one woman she was in her 90s, and she had advanced disease, met all the criteria, had been in the hospital several times, but she had three daughters who were teachers and one who was a social worker. Those ladies took such good care of their mother. She lived 2 years. So she re-upped a few times, but you're right. If it looks like she's stable and doesn't need the hospice services, that happens. And so yes, they graduate out of hospice. But
That
they
little lady, she
uh,
entered when she was 99, was on it for 2 years, stabilized,
uh-huh.
was kicked out, and
Yeah.
lived another 2 years and died at 103, and was just such a catbird. She was
Uh-huh.
very active. She drove until she was 101.
Wonderful. Well, somebody was taking good care of her. All right. Well, you have been a wonderful audience, and I love the questions. I can tell a lot of you have a lot of field experience, and thank you for all that you do. And Stephanie, I'll let you take us out.
Thank you, Dr. Powers. A lot of great information as always. And of course, if there are any questions later, you can follow up with myself, Dr. Wick, Dr. Powers, any of the ENCORE team, and we will do our best to point you in the right direction. Reminder that our next webinar is July 16th, and we will hear from Reverend Michelle Hunter, kind of talking about some of that. She's with First Centenary United Methodist, which for me is literally across the street from my office. They have a respite care program there called Abide Ministry. And so she's going to be speaking on some of the respite, which is kind of a great follow up to Dr. Powers, except you'll just have to wait a month to hear it. So I hope you took good notes. If not, we'll have a recording and you can refresh right before you hear Reverend Michelle. But again, we thank you for your time, and I'll be sending a follow-up email with a recording link just as soon as we can get that uploaded. And of course, Dr. Powers' contact information in mind too. So have a good week, and I guess we won't see you until after the 4th. So have a happy, safe 4th too.